Welcome, everyone. I'm David Brown. I have the honor to serve as the Associate Dean and Associate Vice President for Health Equity and Inclusion and Professor of Otolaryngology Head and Neck Surgery here at Michigan Medicine. And it's my honor to welcome you to the 5th Annual Health Equity Leadership Program at Michigan Medicine, sponsored by the Michigan Medicine Office for Health Equity and Inclusion. I'd like to thank all the organizers for planning today's event and for the speakers for their participation and sharing their knowledge. This program aligns with the Michigan Medicine core values of caring, integrity, respect, inclusion, equity, diversity, innovation, and teamwork, as well as our hospital's base framework of belonging, access, safety and quality, and experience. Michigan Medicine has a deep commitment to health equity and supports our novel healthcare equity consult service. And we also have an institutional set of health equity goals adopted by our hospital president and leadership to have equitable outcomes for Black versus white adult patients with hypertension, and to decrease the influenza vaccine uptake gap for Black versus white pediatric patients. These and other intentional efforts will hopefully lead to the best healthcare outcomes for all our diverse patients, and no matter what their background or identities. The Health Equity Leadership Program has existed for 5 years prior to the pandemic and is another example of our institutional commitment to health equity. Each year, we have a different theme, and each year, I'm very proud and that we're fortunate to have so many expert faculty members to contribute to the conversation, demonstrating personal, professional commitment, as well as institutional commitment to health equity. Today, we will learn about the disparities in the care of women of color and hear from numerous esteemed Michigan Medicine faculty members. Many of you are probably aware of poor maternal mortality of Black women and other women of color. And we wanted to highlight that there are additional healthcare disparities for women of color, in addition to the horrific maternal disparities. We are always looking for health equity and social justice warriors to join us, and hope that many of you might join us as residents, fellows, and our faculty members in the future. Now I'd like to welcome Dr. Marcia Perry, the Office for Health Equity and Inclusion Director for House Officer Programs and Associate Professor of Emergency Medicine, and the leader of tonight's program. Dr. Perry.
Thank you very much, Dr. Brown. Good evening and warmest welcome to everyone to Michigan Medicine's annual Health Equity Leadership Program. We really thank you for taking time out of your very busy schedule to engage with us before the start of recruitment season. We wanted to let you know that in addition to providing a top-grade training at a graduate medical education level, we are also an institution that's committed to changing the course of health and healthcare disparities. As you know, healthcare disparities are well-documented concerns among patients and providers of color. So today, we'll have a conversation about disparities in the caring for women of color. We have a lineup of Michigan Medicine experts who will address this topic in each of their specialty. So again, welcome, and I'm going to introduce you to our very first speaker, who was a resident and now a friend and colleague. So, Dr. Versha Pleasant, welcome, and thank you for coming. Dr. Pleasant is a clinical assistant professor in the Department of Obstetrics and Gynecology. She specializes in cancer genetics and breast health. Before entering medical school, Dr. Pleasant completed an HIV/AIDS program management fellowship for the CDC in Rwanda, and later she was recruited to the CDC in Côte d'Ivoire to continue her work in HIV/AIDS amongst vulnerable populations. She completed her OBGYN residency and her fellowship in cancer genetics here at Michigan Medicine. She's deeply interested in healthcare disparities, particularly in breast cancer and genetics testing barriers facing Black women. Dr. Pleasant will be speaking to us today about disparities in diagnosis and management of breast cancer in women of color. Welcome, Dr. Pleasant.
Thank you so much, Dr. Perry. Thank you, Dr. Brown. Thank you to the entire OHE office for inviting me to this event. It's really an honor and a pleasure. Let me share my screen. And can everyone see and hear?
Yes.
Wonderful. Again, my name is Versha Pleasant. I'm a clinical assistant professor in the Department of Obstetrics and Gynecology here at University of Michigan, and I am director of the Cancer Genetics and Breast Health Clinic, a really specialized clinic where we see patients at increased risk of breast and ovarian cancer, either due to gene mutations or family history, and we also provide care for breast cancer survivors. So I'm going to talk a little bit today about racial and ethnic health disparities, diagnosis and management of breast cancer. The caveat here is that, as we all know, race is a social construct, and I want us to keep that in mind as we go throughout this presentation. And in no way is this a 100% comprehensive of all racial and ethnic groups, but I wanted to highlight some key data and just provide some broad brushstrokes for your understanding of breast cancer and how it disproportionately impacts different groups. I have no disclosures. We're going to start first talking about breast cancer, then move on to genetic testing and the role that genetic testing has to play in breast cancer prevention and risk reduction. We're going to talk a little bit about initiatives that are being done, and I will also highlight some of my research in this area, and then we will conclude the presentation. So first, I want to just bring to light the data from the American Cancer Society showing that among people assigned female at birth, that breast cancer is the most commonly diagnosed cancer among this population in the United States, estimating about 30% of new cancer diagnosis. This is about 297,000 people that are diagnosed with breast cancer each year. And then if you look below, right after lung cancer, breast cancer is the second leading cause of cancer death in the United States. So, these numbers are very, very concerning. 12% prevalence in the United States. That means that 1 in 8 people in their lifetime will develop breast cancer, and that there is a new breast cancer diagnosis every 2 minutes in the United States. That is alarming. So for people that are not personally impacted by breast cancer, you may have a loved one or a friend or a close colleague that has been impacted by breast cancer. Again, from the American Cancer Society, let's take a look at trends in breast cancer incidence rates by race and ethnicity. And this is looking at trends between 2000 and 2019. And generally, we see that whites have an increased incidence in breast cancer, an average of about 133 per 100,000, followed by Black patients, about 127 per 100,000. And lower incidence rates that we're seeing among Asian, American Indian, and Alaskan Natives, although that number is starting to go up for unknown reasons, and lower incidence among Asian, Pacific Islanders, and Hispanic populations. We can't talk about breast cancer without talking about mammography, which is really one of our best screening tools for breast cancer. It is essentially an X-ray of the breast tissue, and it reduces the risk of dying from breast cancer. We've also seen an overall decrease in mortality after Medicare started reimbursing for mammograms in the 1990s. So again, this is interesting, looking at trends in mammography over time. And this is an interesting graph because it's showing that whites and Blacks have higher likelihood of having their mammograms. These are women 40 years and older, compared to, say, people of Hispanic origin or Asian. Although some of the data on this is very conflicting. If you look at a lot of studies, some of the research is suggesting that Black communities, people from Black communities, are less likely to get screening mammograms, which is not necessarily reflected in this graph. And then you see the break here during COVID, which I thought would be interesting to discuss because this one particular study showed a global decrease in mammograms during the onset of the COVID pandemic, which is very understandable as things generally shut down. But that when they compared the rebound rates of mammogram July 2020 compared to July 2019, it showed that white and Black communities rebounded, but they did not observe this same rebound in screening mammography among Hispanics and Asian Americans. And you can see those numbers there for screening and diagnostic mammograms, respectively. So what are the barriers that we're looking at? Why would people not get a screening mammogram? It could be multifactorial. For some people, fear and anxiety plays a huge role. They're afraid of potentially getting a mammogram and then having a subsequent breast cancer diagnosis. For some groups, it is fatalism. Well, we're all going to die someday, so why would I want to know about a breast cancer diagnosis? Sociocultural norms, religiosity. Sometimes there's mammogram misinformation. Sometimes people think that mammograms cause breast cancer. And while there have been some studies showing, obviously, that there is exposure to radiation with mammograms over one's lifetime, that in no way equates the lives saved from mammogram. For some people, pain is an issue, mistrust of the healthcare system, but there are also structural barriers that we have to take into account. Things like cost. For some people, insurance coverage is an issue, childcare. We don't think about these things, that people actually have to make an appointment and actually have to find a way to get to a mammography unit. Sometimes they may live in an area where there is a lack of access to screening mammogram. So these are the 5 dimensions of access to care. So when we talk about social determinants of health, we want to think about these sorts of things, right? Accessibility, affordability, availability, accommodation, and acceptability. And I really like this one study looking at Black women in mammography. It was a retrospective qualitative study, and it was using this framework. And they interviewed these 39 Black women, and they identified barriers in each of the 5 dimensions of access to care. And I just thought I would, put up some of these, these quotes that this one patient here was talking about. Issues with financial assistance and insurance, that if somebody helped them pay for it, then it wouldn't be as much of an issue. Another person talking about, sometimes doctors don't do it. Sometimes it's because of your race. They feel like, well, we won't bother you, just give you some medicine, right? And other people, well, there's a lot of times you're scared what they're going to say. They scare you, right? So some people, fear is a real big issue. They're afraid of the word cancer. They're afraid that if they go looking for something, they're going to find something. Okay. Other data, after diagnosis, when we look at things like care and treatment, overwhelming data showing that Black communities have lower odds of undergoing surgery, lower odds of undergoing chemotherapy. This one particular study showing a 1.73 times higher odds of treatment delays starting 60 days after diagnosis. Imagine that. That's about 2 months. So 2 months after someone has a breast cancer diagnosis, they have not yet started treatment, right? And that's compared to non-Hispanic white people. Higher risk of recurrence, of breast cancer recurrence with delays, and Blacks tend to have longer treatment durations. Another interesting study here showed that Black and Hispanic people were significantly more likely to undergo mastectomy compared to non-Hispanic whites, right? Bigger surgery, when generally, depending on the scenario, the standard of care could be breast conservation surgery, like a lumpectomy. Black and Hispanic people have higher odds of delays in treatment. And obviously here in this study, they're showing a link to socioeconomic status, and that those with higher SES had lower mortality. Interestingly, I wanted to include this study because I wasn't able to find a whole lot of data on Middle Eastern Americans and their experience with breast cancer. But this study compared Middle Eastern immigrants to non-Hispanic white people in California, and they showed that these first-generation Middle Eastern immigrants had higher odds of a non-localized breast cancer. But interestingly, they were 11% less likely to die from that breast cancer compared to their white counterparts. So even though, there was an issue with a cancer in this scenario that had spread, mortality was not as high. And so let's take a look at that since we're talking about mortality. This is, again, American Cancer Society. And if you remember from that first incidence graph, you had white people with higher incidence of breast cancer, and then Blacks. And now you see that line has switched. So the top line is the group with the highest mortality related to breast cancer, and that is that consists of the Black community. then whites, and then American Indians, Hispanics, and Asian Pacific Islanders. So this is a really, really important graph because it's basically saying the data suggests that Black people have a 41% higher chance of dying from breast cancer. So they're just as likely to get a breast cancer, maybe even with a slightly lower prevalence, but they're 41% more likely to die from that breast cancer. And I cannot stress this enough. This is a very, very important statistic. They are more likely to have early onset breast cancer, and Black patients are more likely to have more aggressive subtypes like triple negative breast cancers and inflammatory breast cancers. Okay. And this is a really interesting graph from a study just looking at the rates of triple negative breast cancer. And as you see, that top line is representative of non-Hispanic Blacks. You see that this is a pretty significant rate per 100,000 people compared to Hispanic, Asians, and non-Hispanic whites. So this is a big thing. When we start talking about mortality, yes, it is very important to talk about who is getting the cancer and when they're getting cancer and how aggressive that cancer is. But when we talk about cancer, another really, really important variable here is who is dying from that cancer. And so we think about things like factors like people that may be less likely to undergo screening, people that are having more delays in their treatment. We don't want to undervalue the importance of concepts like weathering and systemic racism and the role that plays on health. People that are more likely to get aggressive subtypes. And we talked about triple negative breast cancer and inflammatory breast cancers, which are harder to treat. And then some groups are less likely to have had genetic testing. And we're going to talk about that in a second. I did want to take a slide to at least mention the intersection of gender diversity. People who are assigned male at birth have a very, very low incidence of breast cancer. We're thinking 1% or less than that. However, again, if you look at the granular data and you start segregating by race and ethnicity, Black people assigned male at birth are more likely to be diagnosed with a breast cancer. They're more likely to have a triple negative breast cancer, which, as we mentioned, is a more aggressive type of breast cancer. Not a lot of data on transgender people and breast cancer. There was a study done in Europe looking at the incidence of breast cancer in trans males and trans females. And the thought is that there may be a lower risk among trans males, particularly those that may be on testosterone therapy, although we don't know the long-term effects of testosterone. And in trans women, we also think that we hypothesize that the risk may be lower simply because there is not as long of a duration of lifetime estrogen exposure to estrogen. But the reality is we don't know the long-term impact of exogenous hormones. And we don't have the data behind people that have had gender affirming surgeries and what their risk may be. So let's talk a little bit about genetic testing. I love Angelina Jolie. I think she's an awesome activist and actress. And she really brought genetic testing to light in this country. Her mother had BRCA and had breast and ovarian cancer and succumbed to her disease. And so Angelina Jolie was tested, and she underwent a risk-reducing mastectomy and bilateral salpingo-oophorectomy, and wrote this op-ed in New York Times, which I really love. And she talks about encouraging people, especially if you've had a family history of breast or ovarian cancer, to seek out the information of medical experts who can help you through this aspect of your life and to make your own informed choices. And while I love that she brought genetic testing to the forefront, and I love her choice of words here, I always look at this quote and I look at the word choices, and I say, does every person have the same choices? And so we're going to talk a little bit about genetic testing and how that may not necessarily be true. And some of the data suggesting regarding uptake of genetic testing that there is generally lower uptake among the Black community. And some of that may be due to medical mistrust. Some may be due to fear of having or discovering a gene mutation, fear of genetic discrimination. But that doesn't explain all of it. This was a very interesting study that was actually conducted in Michigan that showed African-American early onset breast cancer survivors had lower rates of genetic testing. And in this community, any early onset breast cancer survivor meets criteria for genetic testing. But if you look at this population, they cited the number one reason, one of the number one reasons for not undergoing genetic testing is that their providers did not offer it to them. So I want us to really think about that. This is an interesting study done looking at genetic testing among Vietnamese Americans, and some of the barriers cited here included lack of information, fear of the impact of the results, costs came up, and privacy concerns. And these are common themes that we're seeing when we're investigating barriers to genetic testing among all groups. Another systemic review among Latinx individuals note that costs, referrals, communication were barriers. Some providers had implicit biases about Latinx patients that may have impacted their care, despite the fact that many of the Latinx patients in this study were interested in learning more about genetic counseling and genetic testing. So to give you some context as well, once people undergo genetic testing, what do we make of their results? So these are the four major classifications of genetic variants. And just to summarize, people who have variants of strong clinical significance or potential clinical significance are provided with the treatments and interventions, assuming that that mutation or that variant can increase cancer risk. Whereas benign and likely benign, we believe that those are mutations that do not increase cancer risk. But interestingly, there is this category in the middle called variants of unknown or uncertain clinical significance. This is I like to call it the genetic black box, because it essentially is saying you have a mutation that has not been studied well enough and we don't know what to make of it. And so we just monitor these gene mutations. And if we look at some of the data, this is a very interesting multi-center study looking at African Americans with invasive breast cancer. They found that a third of these patients had variants that could not be classified, right? Another study here looking at noted that variants of unknown or uncertain significance, the rates doubled over time. And look at how high they were among Asian Americans, 47%, 46% among Blacks, compared to 24% among non-Hispanic whites. Another interesting study, this was a population-based retrospective cohort, and they basically were looking at about 1,000 patients from 2013 to 2015. And interestingly, if you look at equivocal results among this population, the non-Hispanic whites, about 23%, but then it jumps up to 44% for Black people and 50.9% for Asians. So this is basically saying to us that, yes, we see that there are these gene mutations, but we did not research these populations well enough to know what they do. And this is just a quote from this clinical working group, basically saying for ethnic populations where relatively little genetic testing has been undertaken, that we have these polymorphisms that can't be recognized. These are more likely to be reported as equivocal results, as uncertain significance. This is just a slide showing how we come up with these classifications. We call them genome-wide association studies, and they're basically huge studies looking at large groups in populations. And we're trying to find trends between what is seen in one's genome versus what is expressed phenotypically, right? Are patients with this particular gene mutation actually presenting with cancer? This study showed the representation of different groups in these large genome-wide association studies. And I love this because this is a great pictorial representation between 2009 and 2016. We can see that the percentages have not really changed a whole lot. So 96% of genome-wide association studies in 2009 were comprised of people of European ancestry. And then in 2016, 81%. So people of non-European ancestry, we went from 4% to 19%, which is not that huge of a jump. And then if we go down to break it down further, especially when we're talking about mortality, and for instance, people of African ancestry being an increased mortality, as you can see from this graph, they make up a very, very small percentage of those represented in genome-wide association studies. So ultimately, I love this cover where genomics is failing on diversity. This is a really, really important area that has gotten a lot of attention in the genetic world. So what's being done? I think the first thing we want to talk about is increasing access. So the Centers for Disease Control launched an initiative called the National Breast and Cervical Cancer Early Detection Program. And the goal is to provide over 180,000 mammograms to people who are uninsured and underinsured. And this is going to be a really, really good first step at providing screening care to people at risk. This is Erica Hart, a queer individual who herself was impacted by breast cancer and lost her mother to breast cancer. And as she was undergoing her breast cancer care, she asked for to see images of what it would look like for her to undergo a mastectomy. And she noticed in all of the images that there were no people that looked like her. So she started doing what we call topless activism, and has pictures basically showing what a mastectomy looks like in a person of color and raising awareness about breast cancer, especially among early onset breast cancer survivors. The Thousand Genome Project is also really important, and this is a global initiative looking at how do we categorize and classify and better research genes from people from all over the globe, not just people of European ancestry. Dr. Charles Rutimi, who works at the NIH, really pushed this initiative, Black Genes Matter, and he was featured in Newsweek some time ago. And he has been leading a lot of the initiatives trying to look closer at the association between the environment and the genome and better understanding our genetic risk. And I really like this. This is a very interesting study by the NIH, for which they put $12 million into looking at biospecimens of Black people that have been diagnosed with breast cancers, that we can better understand some of the risk factors. I wanted to just mention a couple of areas of research of mine. As you can see, I'm very interested in variants of unknown or uncertain significance. So we are currently doing a retrospective study looking at the length of time to reclassification in patients of diverse racial and ethnic backgrounds, because there's really very little to no data on this topic to date. The University of Michigan, another project I'm working on, the University of Michigan has launched a mobile mammography unit that's housed at the Ypsi Health Center, with the goal of reaching underserved communities, particularly Black women, with screening mammogram services. And I am spearheading a study called the Genetic Risk Assessment with Mobile Mammography Project, GRAM. It's sort of a playoff of mammogram. And the goal is, at the time of one screening mammogram, they will be offered a rapid risk assessment to determine if they meet criteria for genetic testing. And if they do, we're providing referrals right there on the spot for patients to take advantage of that. And really the goal there is that genetic testing could be a form of prevention among this community. And this is kind of our flow chart. And this project also involves community-based education, right? We can't just go into a community and offer a service. We have to understand the context. Why are people mistrustful of the medical system? And providing education events and information to talk about cancer risk, to talk about genetic discrimination, so that people better understand as they take up this service. And then another area of interest of mine is chemotherapy-induced alopecia. This is an area that for which Black people may be uniquely impacted. A lot of the interventions for conserving one's hair have been geared towards white populations, and a lot of studies have not really gone to benefit Black people who have undergone hair loss related to chemotherapy. So we published this paper in Cancer earlier this year, and we're taking it a step further and doing a photo essay of Black people impacted by chemotherapy-induced alopecia, with the plan for this photo essay to be published in Michigan Medicine in 2024. So please keep an eye out for that. So in conclusion, I hope it was very clear in this presentation that all races and ethnic groups are impacted by breast cancer. Breast cancer impacts all of us. But the statistic that is incredibly alarming is that Black people have a greater risk of dying from breast cancer, just as likely to get a breast cancer, but a greater risk of dying from that breast cancer. We have to address this in a multidisciplinary way. Primary care is really, really important, because primary care physicians are the ones, and OBGYNs prescribing, ordering mammograms. They're sometimes the gatekeepers to genetic testing. So we really have to identify patients early before they even get a breast cancer. And we also need more inclusive breast cancer and genetic research to include people from diverse backgrounds so that we have a better understanding of risk. Here are just a couple of questions that I wanted to put out there for us to think about. What role can healthcare providers play in reducing breast cancer-related racial health disparities? Should we see patients differently, or should we see them all the same when it comes to cancer risk? And how can the uptake of genetic testing be increased among communities who may inherently distrust the medical system? So just some things to think about. I'm really, really appreciative of your attention today. As you can tell, this is an area that I'm incredibly passionate about. I thank you so much for your time, and I would welcome any questions now or during the Q&A.
Thank you so much, Dr. Pleasant. There is one question in the Q&A at the moment, and we are going to encourage everyone to continue to put their questions in the Q&A. We will likely get to most of them during the Q&A session, but since we have maybe about a minute, if Dr. Pleasant wants to address the first question, that'll be okay too before our next speaker.
Great. Yeah, I'm happy to address it. Thank you so much for this question, Annalisa. Do we know why people of color are underrepresented in genetics? Is there a breakdown of it being so to lack of access to care versus mistrust versus unawareness? This is a really great question. So, and I think there are a lot of layers to this. I think that historically, people of diverse racial and ethnic backgrounds just have not been included in these genome-wide association studies for a variety of reasons. Which we can surmise what that might be, but they just have not been included. I think there's also the issue of these groups tend to not get as much genetic testing, and so we therefore then don't know a lot about the genetic diversity in these groups. So it's almost like a vicious cycle. Like, we don't have the data, but part of why we don't have the data is because people aren't getting tested, and people aren't getting tested because of, in part because of the mistrust. But again, I don't want to just chalk it up to mistrust, because as we see from the data, some of it is that they're just not being offered the testing in various scenarios. And that's where you all come into play. You all are going to be the future leaders of healthcare. And so it's really important to be familiar with how, what are some red flags in someone's family cancer history? Who do you send these people to, and how do you assess their risk? This is really, really important. Do you believe that informing certain populations of cultural reasons why they may not get tested, seek treatment, would benefit that community? That's possible. That's absolutely possible. And that's kind of what we're trying to do in the GRAM project. We are trying to meet people where they're at and to debunk myths related to genetic testing, to make it commonplace, to talk about it openly. When I talk to some groups about genetic testing, the first question that comes up is, well, who's getting my results, right? Who's getting my sample? Is the government getting my sample? Is my health insurance company getting my sample, right? And so these are things that we have to clarify for people, that there is a law in place, the Genetic Information Non-Discrimination Act, that basically states that your employer and your health insurance company cannot discriminate against you based on your genetic makeup, right? And so when patients understand that, they tend to say, oh, okay, I understand. And that's good to know. The government doesn't get your sample, right? And that these genetic testing results could save your life. They could benefit you and other family members. So I think definitely awareness and more education among communities is really, really going to help this initiative quite a bit.
Thank you so much, Dr. Pleasant. Any further questions for Dr. Pleasant? We will address them in the Q&A. I'd like to go ahead and introduce our next speaker. Dr. Paul Hillard is an associate professor of anesthesiology and the section head of pain medicine at Michigan Medicine. He attended medical school at Wright State University School of Medicine and started his residency in the transitional year at Akron General Medical Center, and then came to the University of Michigan and completed his residency in anesthesiology, as well as his fellowship in pain medicine. His research interests include acute pain management and outcomes, acute pain assessment and validation, regional anesthesia and outcomes, and of course, healthcare disparities. Dr. Hillard will be speaking to us today on pain management in chronic diseases among women of color. Welcome, Dr. Hillard, and thank you.
Thank you, Dr. Perry, for that introduction. And thank you, Dr. Brown, also for the invitation to speak tonight about this important work. In putting this talk together, here was the event goals that I was sent. And I thought this is a really interesting combination of topics. And I looked to the literature to see what was out there that tied these together. And there really isn't much. So I'm going to break it down, and then at the end of the talk, I'll tie it all together, hopefully for you, by sharing with you how we at Michigan Medicine are approaching some of these heartbreaking disparities in pain management. And really, we need to talk about these four things somewhat separately to kind of get us started. So pain management, chronic disease, women in color. So I like to pose this question to you all. What is pain? I think when I'm in a room full of people and we have a little different interaction, it's interesting the answers I get to this question, because we all know what pain is. We have all experienced pain before in our lives, but it is hard to define. It's a human experience. We all know what that is. It is hard to put into words, and this is not unique to you. This is a challenge that clinicians have had for years. So in 1979, a group of experts known as the International Association for the Study of Pain came together to give us a medical definition of pain, and that served us well for nearly 40 years. We used that definition. In July of 2020, that group reconvened, this International Association for the Study of Pain, and they revised the definition slightly, and then they added some important footnotes to it. So this is the medical definition of pain. It's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I want to call out one of the most important words in this definition. It's and. So pain is a sensory and emotional. It's not or, it's and. So you cannot have pain, or a patient cannot have pain without an emotional component to it and a sensory component. And I think this is extremely important as we start to assess patients and we approach them to understand what they're going through. I'll share with you just a quick personal anecdote. When I was a first-year anesthesia resident, I was post-call. I came home. It was New Year's Day. I had been up all night doing cases. My wife was pregnant. I decided I'm going to cook today. I saw that Rachel Ray had a cookbook out, and they had this recipe for fried chicken fingers. And I am not one to be in the kitchen very often. So right away, this is a recipe for disaster. I had this pan with boiling, basically grease in it. And I managed to catch it on fire. I'm tired. I'm, sleep deprived. We had running water right there in the kitchen, and you see where this is going. When you run something like that underwater, it basically explodes, and that's what happened to me. I had a minor explosion and when we had vaulted ceilings in the kitchen. I looked at this massive fireball rising up. I thought I had burned my house down. When I looked down at my hand, it was charred white, and I ran it under the sink. The flesh fell off in the sink. This was my 10 out of 10 pain. My wife took me to the emergency room. Trauma surgeon came and saw me and said, I was terrified. I thought I'm going to lose some fingers. I can't practice anesthesia. He looked at it and said, oh no, they're not circumferential. It looks really bad. We'll debride this and you'll need some therapy and maybe a graft there, but you're going to be okay. My pain went from a 10 to a 3. So that emotional component is so important. And I can speak to that from a personal standpoint, knowing the implications of my pain was not going to change the course of my life, reduced my pain. And so please, if you get nothing else out of this lecture tonight, know the definition of pain and understand the balance of those two things, and think about that, how confident and reassuring you can be. Just your presence and the words you choose and how you approach patients and how you listen to them, how that can change their experience of pain. There are 6 bullet points that the IASP gave us with this definition that I want to take a couple moments and go over with you. So the first thing they said in their notation is that pain is always a personal experience that is influenced to varying degrees by biological, psychological, and also by social factors. So that biopsychosocial model, very important in pain management. Pain and nociception are different phenomenon, and pain cannot be inferred solely from activation in sensory neurons. Through the life experience, individuals learn the concept of pain. Also very important as we think about cultural influences of pain. Some cultures really amplify pain, and some really mitigate it and try to please physicians by minimizing their experience of pain. So think about that. A person's report of an experience as pain should be respected. That kind of gets back to my example. You've probably all had the observation of walking into a room and a patient, seems comfortable watching TV on their phone and says, "Oh, my pain's a 9." It's not for us to judge what that is. We can't tell what their sensory or emotional state is. And some of the worst pains in life come from things like when we lose someone close to us. That heavy emotional pain. We just don't know what people are going through. So respect the report of pain. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. A really good book on this topic, if anyone's interested, it's called The Gift of Pain by Dr. Paul Brand. It's a bit dated now, but a really great treatment of this topic, and easy read and quite entertaining. And finally, the verbal description is one of several behaviors to express pain. The inability to communicate does not negate the possibility that a human or non-human animal experiences pain. So this was the first time the IASP talked about animals and their experience of pain. So I want you to keep this definition in mind, and I'm going to refer back to this a little bit as we go through the rest of the talk. And I want to call out that top piece, the biopsychosocial model. So when we think about these different topics of pain management, chronic disease, color, and women, as I mentioned, there's not a great body of literature that really ties this together. So we're going to talk a little bit about these things individually, and then I'll bring it together at the end. I could spend a whole semester talking to you about this topic, about racial disparity in pain management. For purposes of this talk, know that it exists. It's well documented. There are people, including my colleagues here, some of them who have gone on to other places who have made entire careers just on this topic. And so racial disparity definitely exists in pain management. Many of these studies, whenever you look at them, come from the emergency room setting and from the ambulatory setting. Not too many of them are in the hospital context, which is I find interesting. And I'm going to share some institutional data with you later around how Michigan Medicine is approaching this and what we have observed here and what we're doing about it, and how that hospital admission is such an important part of the pain management experience. Why do these disparities exist in pain management? There's a lot of reasons for that, but one of them is that it's founded on false beliefs. There are just, societally, there are beliefs that are just not true. And this was illustrated not that long ago in 2016 by Hoffman et al., who published 2 studies in the Proceedings of the National Academy of Science looking at these beliefs. And they found that a substantial number of white lay people, also medical students and residents in the second study, hold false beliefs about biological differences between Blacks and whites. And so in part 1, the participants who more strongly believed in these false premises rated pain lower in Blacks compared to whites whenever they were asked to assess the pain and pain experience that a person was having. And part 2 of this study extended this to medical students and residents and found that a large extent of nearly half of those studied believed these false narratives. And those who held the beliefs, more importantly, in the medical context, made less accurate treatment plans and diagnoses about patients in pain. And this is kind of a busy slide, but this is taken right out of that study, looking at some of the false beliefs. Things like Blacks have thicker skin. Black people have nerve endings that are less sensitive to pain. These are false beliefs, and they interspersed in here some true statements as well, to enhance the power of their study. So there are many different reasons for disparities in pain management, but please understand that even educated people making it through college into medical school and even the level of residency still hold false beliefs about biology of pain and different races. I'm going to move on from this, and we're going to come back to this a little bit later, but I want to get to some of the sex differences in pain. I find this an absolutely fascinating topic. And again, we could spend a whole, you could do a dissertation on this topic. It's absolutely fascinating. So I want to talk both about pain and pain management here, because they're a little different. So women in pain are actually much more likely than men to receive a prescription for a sedative to treat that pain, rather than a pain medication, so an inappropriate therapy. Also, there was this important study published in New England Journal of Medicine in 2000, finding that women are 7 times more likely than men to be misdiagnosed and actually discharged in the middle of having a heart attack. And why does that happen? Well, it's because there are differences in the way people present and the way their pain presents during an acute coronary syndrome. There are biological differences in how this happens. And it also has to do with our training and our understanding of things. Even research has significant bias and disparity built into it. Chronic pain, which I will illustrate to you momentarily, affects women disproportionately to men. More women suffer from have a diagnosis and suffer from chronic pain than men. Yet 80% of all research studies are conducted on men or on male mice or male rats. And so there is a huge disparity in how we even start to understand pain management. There's, right out of the gates, there's disparity there. So why are women more disproportionately impacted by chronic pain? One study shows by Linda Liu and colleagues, published in Pain, shows that women tend to feel pain more intensely than men. So is this a biological or hormonal influence? And the answer is probably some of both. Her study showed that actually about 250 different disease states were represented here, and the intensity is rated much higher in women than men. Most studies, what made this one unique is most studies look at gender differences in pain, and they look at the number of men with a certain disease compared to the number of women with the same disease, and then rate the pain. This one was a little unique and just how vast it was. And they found that the intensity was about 20% higher in nearly all chronic disease states in women compared to men. And so some people may be critical of a study like this and say, well, it's probably just because women are more likely to rate their pain, or they may just rate it higher. And phenomenologically, the pain experience is really the same for a man and a woman, but women just are more likely to rate it higher. And that's actually not true, which I'll show you in a moment, because the pain perception is actually different between men and women. And it is difficult to assess, right? Pain is a subjective experience, but there is a large body of evidence showing that women have genetic, hormonal, psychological factors which influence their response to pain. And data on this exists for both acute and chronic pain states. These are real differences. And whenever you take out the subjective report of things like Liu's study, where she looked at intensity of pain, which was a subjective report on the numeric pain scale, and look at other things that are not subjective, like EMG studies looking at muscle relaxation time, pupil dilation. So when the sympathetic nervous system is activated in the state of pain, pupils dilate. Looking at different brain responses to noxious stimulus in PET scans, women actually experience more pain. And this is not just a reporting difference between men and women. And so this was brought together in a report that was completed in 2007 called the Greenspan Report, which stated that collectively these findings in experimental areas complement clinical research and support the context that sex differences in the report of pain are unlikely simply to be a function of reporting bias and involuntary, because involuntary responses to painful stimulus are augmented in females. I find this absolutely fascinating. There is a real difference in the experience of pain between men and women. And we see this in the acute pain setting as well. The different studies come to slightly different numbers, but the take-home point here is that whenever you're looking at things like a metric of opioid use, women require more opioids to get the same pain relief in the post-operative setting. Now, what I don't want people in the audience to do is take home the message that, well, we'll give women more opioids. That's actually not a good idea, because there are other factors to consider. This study by Dehan et al. Looked at 13 healthy men and 13 healthy women, and did a really interesting study where they had them inhale carbon dioxide and look at respiratory depression effects of an infusion of morphine at standardized doses. And they did this over a two-week period at 2 different times. One time they got the placebo, one time they got morphine, and found that women actually have a very different slope. They are much more sensitive to the effects of respiratory depression than men are. So it's well beyond the scope of this talk, but please be very thoughtful as you think about pain management strategies. Understand that women, especially Black women, are vulnerable to pain and have a different physiologic and response to pain. They experience it differently, but don't just give opioids. This is a recipe for disaster. Have a thoughtful approach to pain management. So at our institution, I want to share with you some of the work that we're doing here. Recall most of the studies that we referenced occur in the emergency room and in ambulatory, less in the inpatient setting. We took a crack at the inpatient setting. I'm involved in some work institutionally, which is called Rewrite the Script. This is an initiative to improve pain management and reduce opioid-related harm. I'm also involved in opioid stewardship, which is equivalent to antimicrobial stewardship. So this is coming up with metrics to identify patients either with uncontrolled pain or inappropriately managed pain at high risk for opioid-related adverse events, and then intervene. And we've recently started a pain pharmacy service to help with this and implement those findings from opioid stewardship. One of the things we did was we asked ourselves, how are we managing pain, and what is the incidence of really poorly or uncontrolled pain in our institution? So we made up a metric called uncontrolled pain. You won't find this in any studies. This is something that we just made up to try to get a baseline. And what I did was use the numeric rating scale, because that's what we have access to. That's part of the routine nursing assessment. And we said, well, if a patient has a pain score of 7, that's pretty high. And if they have 2 consecutive 7s, we define that as uncontrolled pain. And I fully acknowledge there are problems with that definition, right? Some people with chronic pain live at an 8, and you'll never get them below a 7. But we wanted to try to start picking up patients who came into the hospital for surgery, for procedure, for medical admission, and had something happen to them, and then their pain was poorly controlled. And so we look at the 2 consecutive 7s and call that uncontrolled pain. And whenever we pulled data on this, we find that African American females had a 41% rate of uncontrolled pain during a hospital admission, followed by Black males, followed by white females, and finally white males at 21%. This really kind of gets us back to what the literature is showing us. And so we did a deeper dive into this. We wanted to understand, what can we do to reduce this disparity or eliminate this disparity? And we took this data and went very deep into it. We noted that Blacks overall were 1.423 times more likely than whites to have uncontrolled pain, to meet this metric, but also had higher initial pain scores. this is very important. You know, when we talk about those 6 bullet points and the societal implications of pain and the stress that people are living with due to systemic racism and other things. And remember that definition, sensory and emotional. People are coming in with higher pain scores. And I think what we did was uncover something that existed outside the walls of our institution. But we weren't satisfied there. We did a deeper dive to see, is there anything we can intervene on? And we looked at a lot of different metrics. We found that Blacks did have fewer pain scores taken than whites, as well as slightly fewer total opioids during an encounter, but on a daily basis, it was equivalent when we averaged that out. Blacks were as likely to have a pain consult as whites and actually received it sooner than whites, but the difference was not significant. Blacks received their first pain scores quickly as whites and had uncontrolled pain scores actually recorded sooner. And here are all the different things that we looked at. And I'm not going to read every one of these things to you, but the take-home point here was that despite doing a very deep dive into this data, we did not find a smoking gun. And I think this highlights some of the approaches to patients in the ER versus ambulatory setting versus inpatient admissions. When you have some automation brought to the system is somewhat, doesn't know who those patients are, and they tend to be treated more equally whenever you're working off of order sets and automation and consults that come through. So there was not a smoking gun here, but this doesn't mean that these things don't happen. And disparity doesn't exist in the inpatient setting. I'm not going to play this video for you because my experience playing videos and webinars is not great. But if you have not seen this or are not familiar with it, I would encourage you to look at YouTube and type in Dr. Susan Moore. I make my fellows watch this video. Actually, it is one of the most heartbreaking things I have seen. Dr. Susan Moore, it was a African-American female admitted to one of the Indiana hospitals with COVID, and she was detailing her experience around pain management, her fear, and she ultimately died of this disease. And to see her blog this in her last words is very sobering, and I think it's time well spent. I think every one of you should watch this video. So I want to try to weave this all together. I hope that I have helped you understand what the definition of pain is, understand that it's a sensory and emotional experience, and review those bullets. I think it's really important to know that. I think if you know nothing else but the definition of pain, it will help inform your treatment plan, and recognize there could be a large emotional context of pain. If someone's livelihood is going to be impacted, if they can no longer provide for their family, if they can no longer function the way they saw themselves working, this will amplify their pain. And just your approach to that patient, the words you choose, the compassion you show, looking them in the eyes, listening to them, letting them tell their story, these are things that are going to enhance their experience. And some other work I'm involved in, we've actually created something called a pain profile, where we've hired extra nurses to go and identify these patients at high risk for disparities in pain management, listen to their pain stories, memorialize it in the record, and then bring more resources to them. So that all stems from knowing what pain is. Also know that there are societal and cultural biases which influence the experience of Black patients. They're more likely to experience uncontrolled pain, and know that women experience pain more intensely than men. And again, that's not just a subjective thing. The more objective and scientific measures of pain management validate that. I'm happy to entertain some questions now. I think I have finished with a couple minutes to spare, and I will also stick around to be present for the QA session. My email is here, and you are more than welcome to reach out to me with any questions you may have about this topic.
Thank you, Dr. Hillard. You do have a question from Annalisa in the Q&A. It says, does stress/stressors have an effect on the pain experience of any individual?
Yeah, thank you for that question, Annalisa. Unequivocally, yes. Stress and stressors have a negative experience on pain, and not just psychological stress and stressors, but we think about the physiologic consequences of uncontrolled pain. So you can really apply this both to acute and to chronic pain management. Part of the challenge, I think, in doing a good assessment of our patients is to be able to separate those things and appreciate what stress they may be dealing with. Just ask your patients, what keeps you up at night? What are the breaking points for you? What stresses are you dealing with? And you'll be shocked at what you find out. And oftentimes just having that conversation can help with this. But yeah, the simple answer to your question is yes, without doubt. Stress and stressors amplify pain. We know this.
So Dr. Hillard, I wanted to tell you that study that you showed where they asked residents and students their perception of pain, one of our residents was a participant in that study and told about his experience with the questionnaire and was surprised about the questions in that study, and gave his healthcare disparities talk on this exact topic. We have one more question, that sickle cell pain is often a challenge. There appears to be no standard in acute pain crisis. Is there work around this happening here, I guess?
Yeah, a great question. Thank you for bringing that up. And this is when I was talking about the effects of respiratory depression and don't just give more opioids. I'm aware of a few cases where this is exactly what happened in sickle cell management. It was a pure opioid centric approach, and that this can have very negative outcomes. So there is work around this, to be sure, but it's dangerous to lump everyone into a category and say, for sickle cell, we're going to treat it this way and have an algorithm. Pain management really needs to be customized to the patient. Some people will have slight genetic variations where they just respond better to one medicine compared to another. You need to think carefully through the pain. Is it more nociceptive? Is it more neuropathic? What is their, do they have a background of chronic pain? Often patients with sickle cell disease have avascular necrosis. And then during an acute flare, you really need to do a thoughtful evaluation and individualize a treatment plan. Yes, it's challenging, but it's a rewarding challenge. And really, when you get it right, these patients are extremely grateful. I'm reminded, I won't go on too long here, but I saw a patient recently. She had sickle cell. She was admitted to the hospital for a long time, consistently rating her pain as a 9. And no matter what we did, her pain was a 9. I would go to her room. I was on service. Finally, I just apologized. I said, I'm sorry you're having this experience. We're really not treating your pain adequately. And she stopped me. She said, oh no, this is the best my pain has ever been managed. You people are listening to me. You're talking to me about it. She felt we were partnering with her in her pain. And she acknowledged she had very high pain scores, but do not underestimate the other aspects of pain management, what you can bring to this. So yes.
I think we will table Teresa's question for the Q&A, and then move on to having the next speaker starting on time. So our next speaker is Dr. Helen Morgan. She's a clinical professor of obstetrics and gynecology and learning health sciences at the University of Michigan Medical School. She's currently the director of the residency preparation course at Michigan and is the co-investigator of and program evaluation lead in a very huge grant on reimagining residency, right resident, right program, ready day one. Her research interests includes undergraduate medical education, the continuum between medical school, residency, and also diversity in medicine. She's also interested in competency-based assessment and technology in medical education. She has many other professional involvement, including co-director of the Path of Excellence on Scholarship of Learning and Teaching, director of the M4 Clinical Competency Assessment, Black Medical Students Association faculty advisor, and member of the Association of Professors of Gynecology and Obstetrics. Dr. Helen Morgan, welcome. She will be speaking to us today about challenges in well-being for women of color. Thank you.
Thank you. Thank you for that very generous introduction, and thank you for having me, and thank you all for being here tonight. I would like to pivot and talk about us, away from patients, and more about us as learners, as physicians, as providers. And if the audience wouldn't mind putting in the chat, are you a third-year medical student, a fourth-year medical student, a staff member, a faculty? I would love to know kind of who my audience was as I'm pulling up my slides. So if you don't mind indulging and throwing it in there, it would just help me to orient to who my audience is today. Susan Moore, that Dr. Hilliard mentioned, was one of my medical school classmates here at Michigan. We graduated in the class of 2002 here at University of Michigan. All right, so there's my slides here. This is a hard topic. We're talking about well-being. And so what I want to talk about, I really want to frame it in the context of our journeys that get us through medical training, our journeys that brought us to medical training. I'm going to talk a little, I do want to give a little content warning that I'm going to talk a little bit about generational trauma in the context of my own family, because I think that informs so much about our journeys and what we bring as medical students, as residents and physicians. And then we're going to switch gears a little bit and do a little bit of a fun, I hope you find it fun, kind of what if exercise. And then I'll delve into some of the literature on medical training and faculty life. And then I'll end on a more positive note, again, on kind of how some tips and tricks for optimizing our well-being. Thank you all for putting in the chat who you are. So I'll start first with my journey. So this is me and my husband, Dan, who is also an obstetrician gynecologist here at the U, and my two daughters, Maddie and Hazel. They're 16 and 13 years old now. And I was born and raised in Ann Arbor. Here I am, like in second or third grade, here with my parents. My older brother and my little brother hadn't been born yet. My parents came from Korea because my dad came first to Atlanta to get his master's degree, and then he got his PhD here in Ann Arbor, and then they still live here. And I was born when he was getting his PhD. I don't share this story very often, but I think it's very relevant to our conversations today. But my parents had a daughter who was born before my older brother. And when they were new immigrants in Atlanta, she died of meningitis. And my parents talk about how they brought her to the pediatrician's office every day for a week and kept getting sent home. And then she came to the ER and then she died. And so, these stories, they obviously have informed my journey into medicine. I'm going to kind of talk a little bit about it at the end here. But I also want to talk about my husband's journey just a little bit, not too much, just a little, because that's his story to tell. But there's my husband, the little baby there, and that's his mom, Catherine, who's passed away since then, and his father, Dan. And his father used to be an orthopedic surgeon before he retired. And their whole family revolved around his professional success, right? So his mom was a nurse, and she stopped working when the kids were born. And when he was in Vietnam, she spent months like getting his practice ready for him, so that when he came back from Vietnam, he like had his orthopedic surgery clinic like set, because she had done all this work to get it ready. And I bring up that story because I think a lot of our models still revolve around him. You know, the guy who had the wife at home, the whole family that was centered on his success and following him wherever he needed to go so that he would do well. And I have a wonderful friend and colleague named Abby Winkle. She was the program director at NYU in my specialty in OB-GYN. And she wrote this wonderful paper that has this provocative title, Every Doctor Needs a Wife, an old adage worth re-examining. And it's just a wonderful paper. And one thing that she talks about is that, you know, I am so grateful about how far we've come because my mother and my my husband's mother did not have the agency that I have in terms of my career choices and what I've been able to accomplish. But as we've had these opportunities, I love what she said here, but women have assimilated rather than changed the systems they entered. Entrenched gender archetypes continue to reveal values and stereotypes. And so this is my fun little what if exercise. What if medicine was built to support women of color? You know, because it kind of is still kind of built to support my father-in-law. What if medicine was built to support women of color? And I'm just going to spend a quick little segue in this fun little exercise. So I'm a gynecologist. We're going to talk about menstruation, of course. And I don't know if any of you have seen this very, very clever piece that Gloria Steinem published in this magazine in the 70s. And it's if men could menstruate, and it's gold. You can, you know, pull it up and find it on Google. But she said, if men could menstruate, men would brag about how long and how much. Congress would fund a National Institute of Dysmenorrhea. Doctors would research little about heart attacks, but everything about cramps. Sanitary supplies would be federally funded and free. And of course, some men would still pay for the prestige of commercial brands such as John Wayne tampons, Muhammad Ali's rope-a-dope pads, Joe Namath jock shields for those lighter bachelor days. Medical schools would limit women. Of course, women couldn't go to medical school because we'd faint at the sight of blood. And menopause would be celebrated as a positive event, the symbol that men had accumulated enough years of cyclical wisdom to need no more. And so my take is, what if medicine was built around women of color? And so here I am as a fourth-year medical student here at Michigan. What would our medical training, what would it look like if we had always been in charge and we were still disproportionately in charge of everything? So of course, we would have learned about the 60-kilogram female as the basis of everything. And menstruation probably would have been the first thing you learned about in medical school. What if our walls, you know, if all of our walls were covered with photos of amazing women of color from the present, from the past, all of these icons that had shaped the house of medicine? And what if every specialty was looked like it was created for me and created for my peers? Wherever you went, people would say, I can see you becoming an orthopedic surgeon or an ENT or a family medicine doc. You look like you would do well here. We can only imagine what parental leave would look like for individuals who chose to have a family during medical school or during residency. The Harvard Business Review would write papers about, why are so many male physicians quitting? What's going on here? And then I thought it'd be kind of fun to think about, you know, tonight we are here to talk about disparities in the care of women of color. What would this night look like if women of color had always been disproportionately in charge and were still disproportionately in charge of everything? So I know you can put things in the chat. I would love for people to put in ideas of what would be the topics for our health equity leadership program tonight. Would it be why isn't erectile dysfunction being funded? You know, like, what, you gotta have fun with this. Think about what it could look like. But of course, that's not the reality. That's not the world that we live in. Women of color have not always been in charge and are not disproportionately still in charge. And this hallway looks like it's from yesteryear, right? this is up now. This is a hallway in Michigan Medicine. I was doing a faculty retreat over in Towsley, and I was like, what in the world? It's like this hallway. Every portrait is filled with pictures of like this guy. I'm sorry if you guys can hear my crazy dog in the background. So let's talk a little bit about what is the literature about the reality of medical training and faculty life? Because I think all of this informs any sort of intervention about what are some of the challenges and what are some of the correct interventions to make this better. So Derwin Boatwright is just this amazing med ed researcher, and he's at NYU right now in emergency medicine. And he has done such a tremendous job of looking at big data sets and seeing what does the big data show? Because when you look at small data sets, they're always problematic, right? Every time I fill out a survey, I fill out that I'm an Asian OB-GYN who's clinically at East Ann Arbor. So a lot of these smaller surveys, I'm like, well, they're anonymous, but they're not really anonymous. But if you look at these big data sets, then you can actually look at some of the systemic issues. And he's looked at so many important issues. I'm just going to highlight a few things. So he looked at the prevalence of medical student mistreatment by sex, race, ethnicity, and sexual orientation. Looked at 27,000 U.S. medical students who completed the AAMC graduation questionnaire. And this table, I know, is a little bit busy in a smaller font, but it basically divides the students by white students, Asian students, underrepresented medicine, multiracial, and then looks at these different questions. So if you look at the question, have you ever been subjected to racially or ethnically offensive remarks or names? 2.5% of white students, 12.9% of Asian students, 18.9% of students underrepresented medicine, and 9.6% of multiracial students agreed to that statement. And then if you look at the question, have you ever experienced race or ethnicity-based discrimination? 3.8% of white students, 15.7% of Asian students, 23.3% of underrepresented medicine students. That's 1 in 5, and 11.8 multiracial students. I think he took that same data set and then looked at, okay, so look at mistreatment and what's the association between mistreatment and burnout. Oh, sorry. And then, sorry, forgot one more thing. And then there was a higher proportion of female, underrepresented medicine, Asian, multiracial, or lesbian, gay, or bi students who reported 2 or more types of mistreatment compared to their male, white, and heterosexual counterparts. And so this next study looked at the associations of mistreatment with burnout. So same kind of AAMC graduation questionnaire. And it showed that underrepresented in medicine medical students had moderately higher levels of exhaustion-related burnout, and they were more likely to be in the top quartile of those who experienced exhaustion-related burnout. He's also looked at racial and gender differences in terms of who is elected into the AOA Honor Society. So he looked at residency applications for 4,655 U.S. medical students back in 2014, 2015. And he showed that even after controlling for standardized test scores, research productivity, community service, leadership activity, and gold humanism, Black and Asian students were less likely to be elected or selected to AOA than their white counterparts. He also looked at AOA membership and parental income. And this table is amazing because it shows this direct correlation between family income and chance of being elected into AOA. Also showed this work also demonstrated the differences where Black, Asian, and multiracial students and Hispanic students were less likely to be elected into AOA. I'm just going to review a few of the other studies that he's done. He was involved in this qualitative work, looking at the experiences with racism among Asian American medical students. And this showed that Asian American students reported feeling invisible within the medical school. So it took them the whole first year to be able to tell me apart from the other Asian guy, while also a target of anti-Asian racism. He looked at attrition of students from MD, PhD training programs, and Black students had a greater than 50% higher odds of leaving an MD, PhD training than their peers, and 29% of Black MD, PhD students did not complete their training. And he also looked at research experiences and publication, where women had 10% fewer publications, while Black students had 15% fewer publications, and Hispanic students had 7% fewer publications. I saw that there are many medical students that were here. He's looked at differences in the MSPE, where white applicants were more likely to be described as outstanding, exceptional, or the best, and Black applicants were more likely to be described as competent. And for all of you who are going through your clerkships, who've just gone through your clerkships, this is another study that showed that in 4 of the 6 required clerkships, grading disparities were found to favor white students over either underrepresented medicine or non-underrepresented medicine racial minority students. This was a really clever study that was done of general surgery residents, right? They took this survey at the time of their in-training exam. And this really important work showed that bullying was common during general surgery residency, where 43.8% of the respondents, these were current general surgery residents at the time, reported that they were occasionally bullied, and 18.1% reported frequent bullying. And the factors associated with frequent bullying were being female, being divorced or widowed, lower in training exam scores, being from a racial or ethnic minority, being in a community program or training in the Northeast, and importantly, being bullied was associated with much, much higher chances of being burnout, considering suicide, or thoughts of leaving the program. This was a qualitative study that looked that asked residents about the role of race and ethnicity in their training experience, and residents described almost a daily barrage of microaggressions and bias, minority residents being tasked as race or ethnicity ambassadors, and challenges negotiating the professional and personal identity while being seen as other. Sarah Whetstone is a colleague of mine. She's an OB-GYN. She's the program director at UCSF, and she wrote this really beautiful piece about what it meant. This was published just this year, on her reflections of being a Black program director. And she describes, it's so beautiful, and I'm overwhelmed with the responsibility of educating Black, Indigenous, and people of color residents in a system that reflects the inequities of a society in which we live. My heart hurts when Black and Brown residents describe the traumas they encounter, the evaluation worded to suggest they are incapable of learning, the touching of their hair or body without their consent, the nurses undermining their expertise in front of patients. And despite the realities of medicine, I still aspire to facilitate our residents' transformation into exceptional physicians while simultaneously centering their humanity, allowing for rest, and providing space for family building and inspiration. And I work my hardest so that our residents can find their paths and realize their dreams. And, I talked a little bit about trauma and generational trauma, but we have to, as we think about well-being and some of our challenges, the fact that individuals who experience trauma have different experiences when they are faced with patients going through these sorts of traumas as providers, when they see it, talking to their patients, when they see it happening to their patients. But there's also this idea of vicarious resilience that we bring this wealth of experiences to our journeys that helps us to also figure out how we are going to best deal with all of the challenges that we are faced with. So there's a lot of studies. I'm not going to go through all of these about the experiences and challenges of people of color, of women of color in the faculty world. I'm just going to summarize it, of course, with some bullet points that we know that people of color, and especially women of color, are less likely to receive NIH funding, less likely to be promoted. There's decreased compensation. We know that discrimination is associated with higher burnout. I think everybody is aware of the phenomenon of the minority tax, of being asked to do much of the hard DEI work, sometimes in an uncompensated way. And then this whole idea of who's allowed to feel. One of our medical school graduates told this wonderful story. She was a woman of color during her 4th year of residency. She felt empowered at that point that when her chair sent out a journal article about a physician, a surgeon behaving badly in the OR, she was able to call him out and say that this does not apply to me because I would never be allowed to act like this in the operating room. And so this is not a conversation that resonates with me when I know that this is something that would never be tolerated in the first place. And then I'm just going to highlight one paper that we published. This was data from before the pandemic, looking at faculty life, looking at gender, and looking at the different roles that many of us play, especially in parenting for women. So this was a survey of physician faculty at Michigan Medicine in 2019 before the pandemic. And just wanted to highlight that both genders felt like female physicians who had children fall behind in the promotion process. In this table here, the light green are female physicians and the darker green are male respondents. And this question, I think, this question and the responses are especially sobering, that most female physicians did not feel comfortable discussing work-life integration with the department chairs of female physician. Their mean response is 3 or neutral. And then if you looked at among all the parents, female physicians were more likely to have turned down a project, turned down a leadership role, or not participate in a committee. But if you look at those numbers, like both, the respondents, if you look at it by male or female respondents, they have very high percentages, both of them. So I have a role in my department as associate chair of faculty development and faculty life. And so when I think about all these things I've talked about, the minority tax, discrimination, burnout, NIH funding discrepancies, promotion discrepancies, decreased compensation, they're the base of these additional challenges, especially for women. I meet with all of our new faculty in my role, and there are these, especially for new faculty, because I meet with all of our new faculty right when they start, that many of our junior faculty are starting their families, so have either little kids or planning pregnancies. The family stresses are always kind of there, because I know that many of us who are older are also now dealing with our parents and the expectations of the wife and what she's supposed to do for the parents. So there's the intersection of the family issues, there's the less mentorship, support, or guidance. And in the midst of that, I'm in a surgical specialty. So you're having your first complication, you're having your first bad outcomes. And so all of this is all intersecting together and imposes many, many challenges. And Adrienne Haggins, one of our emergency medicine physicians here, published this really beautiful piece in Academic Medicine in 2020 about being seen, heard, and validated to promote a sense of belonging for underrepresented in medicine physicians. And she describes some of the interventions that need to address all these different intersecting stresses. And she proposes very concrete, actionable recommendations to provide faculty skill development for cross-cultural mentorship, to create inclusive spaces, and to rethink productivity metrics. So I'm going to end with just a few kind of pearls of wisdom that I have found to be helpful, either that have been passed down to me, or I have, you'll see I borrow or cite from other people that I admire. So, first, to find your people and develop the relationships, because I think that for many women, that work, developing the relationships is often the thing that falls lower on the priority list, because there's juggling so many other things, right? So now that conferences are happening in person again, so many of my colleagues and friends will fly in super late the night before. They'll give their presentation and they'll fly out again because there's so many things that they're trying to juggle. But then you miss out on all of that important relationship building with the people that can be your mentors, your sponsors, and your role models. And I know that I would not have been able to accomplish anything in my professional career if it were not for the mentors and the sponsors and the role models that I've had. I love this quote from Michelle Obama, that life has shown me that strong friendships are most often the result of strong intention. Your table needs to be deliberately built, deliberately populated, and deliberately tended to, because we're so busy taking care of tending to so many other things that sometimes we're not working on those relationships as well. The second thing is to keep fighting the fight, that you have the fire to fight, and being very respectful that sometimes you don't have the fire to fight the fight. This is a quote from an emergency medicine doc out at Stanford that I love, that resonates so much with me, that the best research is done out of spite, that I think that all of us can attack these scholarly projects that we feel the most passionate about. And so we've already talked tonight about so many different important issues, but what do you have the fire to fight? This is a photo of Tate Shanafelt out in Stanford. He's done some really cool work that shows that if 10% of your work aligns with your mission and values and purpose, then your burnout rate for the other 90% is so much better, because you're fighting the fight that you want to fight. This is another Michelle Obama quote. I believe that each of us carries a bit of inner brightness, something entirely unique and individual, a flame that's worth protecting. When we're able to recognize our own light, we become empowered to use it. When we learn to foster what's unique in the people around us, we become better, able to build compassionate communities and make meaningful change. I like listening to memoirs when I'm walking my dog, and Billie Jean King's memoir was so good. And she talks about these three simple life lessons of one, emphasizing relationships, keep learning and learning how to learn, and to be a problem solver, to identify where are the gaps and then start working on the solutions. And it's such advice gold. And I think I have one or two more. Just set your boundaries. I took email off my phone a couple of years ago, and it's been kind of amazing. I don't miss that much. I have perimenopausal sleep fragility, so I don't look at any electronics after 7 o'clock. And again, I don't miss that much. And the amazing thing for me right now is that my girls are old enough that they notice. They're always like, "Why is Dad always working on the nighttime and weekends? And you never are." And I always says, "Because I'm better at setting my boundaries than your father." So know what those boundaries are, and protect yourself so that you can have the fire to fight the other fights. And then my last piece is just to give ourselves grace, that we set such high standards and expectations for ourselves. And we just have to say that what you're bringing to the table is enough. I tell this story very lightly, that I went to visit a colleague of mine who I respect so much. She's such an amazing leader. She's such a great medical educator. She's a senior associate dean of a medical school right now. And I was staying at her house. I was at her house because I was at a conference in Providence. And I opened up the closet in her guest room, and it was such a mess. And it made me so happy to my soul that this wonderful person had the messiest guest closet. And that's okay. We have to give ourselves grace. And then I brought up that really horrible story from my family's past. And I just brought it up knowing how hard it is to tell this story, but also knowing how it informs so much of these things. So in 2020, this woman emailed me out of the blue that I worked with her when I was a medical student here, when her child was on the pediatric surgery service. And she tracked me down, even though I have a different last name now than I did when I was in medical school. And she wrote that on April 10th, 2001, she brought her son into the clinic, of the pediatric surgery clinic in Michigan Medicine. He had a CT scan that revealed a mass in his abdomen. And the resident and the faculty came in and was talking and saying all these really big, horrible, scary words in front of her and her husband and her son. And I just remember taking the kid out of the room. I just remember like, this is not right. This should not be happening. I remember like taking him out and playing Game Boy with him. And he passed away probably within 6 months of this happening. But she wrote me this, that every year during the week of April 10th, she thought of me because of what I had done in the room, and found a way to contact me. And I think that is some of that vicarious resilience we talk about, that all of these experiences and horrible, terrible things, they inform who we are as an individual, as a physician, as a learner, as a medical student, and our patients. So I appreciate all of you listening and taking the time on this beautiful day. And I am looking forward to answering questions.
Hey, thank you so much, Dr. Morgan. I have lots of questions for you later also. So Looking forward to the Q&A where we'll get to talk a little bit more. I'm going to go ahead and introduce the next speaker, and then we'll get back to the Q&A right after that. I think I see Dr. Colvin here. Thank you, Dr. Colvin, for joining us today. We're looking forward to your presentation. So I'd like to introduce Dr. Colvin. She's a professor of internal medicine and a cardiologist who specializes in advanced heart failure and transplant cardiology and in general cardiovascular diseases. She received her medical degree from the University of Alabama and completed her general cardiology fellowship at the University of Miami and advanced heart failure fellowship at the Cleveland Clinic. She completed a master's in clinical research at the University of Minnesota School of Public Health, and she serves as the medical director of the heart transplant at University of Minnesota. She's currently the director of the Heart Failure Network Strategy in the Division of Cardiovascular Medicine at the University of Michigan. She's also the clinical specialist for a scientific registry of transplant recipients, where she is involved in heart allocation. Her scholarly work focuses on improving post-transplant outcomes and detecting the treatment of cardiac allograft vasculopathy. There's much more, but I'm going to save it and give Dr. Colvin a chance to talk to us today. And she is going to talk about cardiovascular diseases in the women of color. Thank you, Dr. Colvin.
Thank you. So I'm going to share my screen and hope this all works out well. So I don't know how this is showing up for you.
We're not seeing yours.
Yeah, right. And showing the. Are you seeing probably some old notes here?
Yeah.
Okay, I'm sorry about that. Let me just get out of this for a second and just go to the presenter view. Sorry. From the start. Okay.
Perfect.
Is that working now? Perfect. Thank you. Sorry about the technical issues. And thank you for the introduction. As Dr. Perry mentioned, I'm a heart failure transplant specialist and currently the medical director for the heart transplant program. So I'm closing up this session with cardiovascular disease in women of color. And it's important to note that there really are not a lot of data. I know when I started looking at this, there's a lot of information on disparities, and we'll go through that and also discuss some of the unique challenges to equity and discuss some potential solutions in 20 minutes, I believe I have. In some areas, we may talk broadly about Blacks or about women, but just recognize that you can extrapolate from those positions to women of color just because of the risk factors. And you'll see what I mean as we go on. So first of all, why do we ever discuss heart disease? Heart disease is the leading cause of death in the US, and despite being underappreciated in women for a long time, heart disease is also the leading cause of death for women in the US. It's the leading cause of death for African American women as well. Heart disease affects women at all stages of their lives, from very young age through menopause. And if you look at the lifetime risk, it's about 1 in 16 women are affected with heart disease, and specifically with coronary artery disease. And another important statistic, 1 in 3 women die from heart disease each year. And this is just showing the incidence of cardiovascular disease in Black women, 49%. So what are some of the common types of cardiovascular disease? Coronary artery disease, heart failure, valvular heart disease, and stroke. And those are the main types that we'll be discussing in this talk, although congenital heart disease is another type of cardiovascular disease. When we discuss heart disease and disparities and heart disease in various populations, it's important to understand what those risk factors are, because that will help you to understand why there might be disparities in outcome and disparities in incidence and prevalence. Some of the traditional risk factors, I think most people are aware of these: diabetes, physical inactivity, hypertension, dyslipidemia, and diet. But some non-traditional risk factors may be more prevalent in women and may help to explain some of the differences that we see, such as baseline inflammation level and anti-inflammatory response. There are data that show that the response to critical illness and sepsis might be different. Adverse pregnancy outcomes, and we'll discuss that a little bit at the end, and how it relates to cardiovascular disease. And then there's stress, sleep disruption, race and racial discrimination that might play a role in the disparities that we see in women of color. Well, in the next few slides, I'm just going to highlight some data about the disparities in morbidity, mortality, outcomes in different types of cardiovascular disease. Heart failure, for instance, is my specialty, and we see disparate outcomes and access and application of therapies along the entire continuum of heart failure, from the diagnosis of heart failure to the application of advanced therapies. And if you look at morbidity and mortality tend to be significantly higher for Black women when compared to white women, on an order of 2.5-fold higher. Mortality is also higher when it's age adjusted. And if you look at the distribution by ethnicity, Black women have the highest mortality from heart failure. This is followed by non-Hispanic white women, by non-Hispanic Native Americans, and then Hispanic women, and finally Asian or Pacific Islanders. Women have the lowest mortality from heart failure. Stroke and coronary artery disease tend to be highly prevalent starting at a very young age, even among women at age 20 or greater. If you compare non-Hispanic Black women to white women, the prevalence of stroke is almost 2-fold higher. If you look at the incidence of stroke, also higher. Prevalence of coronary disease in some studies, the mortality from stroke and coronary disease, and treatment. And this is really important, that women as a whole tend to receive less revascularization, which is treatment for coronary artery disease after myocardial infarction. But also postmenopausal non-Hispanic Black women tend to receive less likely to receive revascularization in the setting of a myocardial infarction. Hypertension, we know that hypertension tends to be highly prevalent among Blacks compared to whites. But if you look at women, non-Hispanic Black women, they have the highest adjusted prevalence of hypertension, which is 1.5 times greater than that of Hispanic and non-Hispanic white women. The lifetime risk of developing hypertension, I mean, this is pretty extraordinary, 85.7% in Black women, which is incredibly high. And these are good data from our very large epidemiological studies, Cardia, Eric, Framingham. And finally, awareness, treatment, and control. I think we know about hypertension in the African-American community, so treatment and awareness tends to be pretty high compared to other communities, but the rate of control is lower. So why are we seeing, these differences in cardiovascular disease? And it's going back to those risk factors. There tends to be a disproportionate burden of risk factors that are associated with cardiovascular disease. Diabetes tends to be higher, statin use tends to be lower, Obesity tends to be substantially higher, and diabetes leading to death tends to be higher. So severe diabetes tends to be more than twice the rate of non-Hispanic whites. I mentioned stress and racism and social determinants of health as risk factors. And there's a growing body of literature that shows the relationship between stress and racism and social determinants of health with cardiovascular disease. And this is data from the Women's Health Initiative. Women who had higher stressful life events were more likely to develop cardiovascular disease. And they looked at different age groups, particularly in older women when they stratified by age 55. It was higher, and also when they went up to age 65. The incidence of cardiovascular disease was higher in those groups when women suffered stressful life events. Hypertension has been shown to be associated with discrimination, and that association tends to be stronger among African American women. Social isolation, something that we saw a lot of during the pandemic, increases the risk of cardiovascular disease in all people, in all women, but you can see there's a greater incidence when you compare Black women to white women. Socioeconomic status and race. Again, we know that these things tend to affect cardiovascular health negatively, but you can see the response to these challenges tends to be greater in Black women. And finally, occupation. Black women are overrepresented in healthcare professions at 13.7%, which is twice the representation in other in the U.S. labor force, which is 6.9%, which was a surprising statistic to me. But they tend to be employed in the lowest wage and most hazardous jobs. So that's something that, again, can create additional stress, which increases the risk of cardiovascular disease. I mentioned interventions for cardiovascular disease. Non-Hispanic Black women and men are less likely to receive intervention for aortic stenosis. So over the past, I would say 5 to 10 years, we've seen a growing use of transcutaneous interventions for aortic valve stenosis. But what we're seeing is that both surgical and transcutaneous interventions are less likely used in Blacks, and women are less likely to receive coronary interventions. And as I mentioned, the application of advanced therapies, transplant and LVAD, tends to be differentially used in women and also in Black populations. So this is a slide that's taken from another talk, but it just talked about where we find disparities among people of color, among the continuum of cardiovascular disease, and management being one of them. This is a study that looked at ICU care. It's an important part of management for people who are critically ill. Who provides that care is really important. And when they compared the outcomes of African Americans and whites who received care in an ICU, that found that African Americans were less likely to receive care by a cardiologist. And these are patients who had cardiovascular disease. Now, why is that important? Does it matter whether the care is provided by a cardiologist or an intensivist? And yes, it was very important, because care that was provided by cardiologists improved survival in both Blacks and whites. But if you're not getting the care at all, then clearly your outcome may not be optimal. And this is another study evaluating racial differences, but also sex differences in outcomes of patients who presented with myocardial infarction and cardiogenic shock. And so these patients are at high risk of mortality and typically seen in an ICU setting. And when they evaluated in-house mortality, revascularization, the use of mechanical circulatory support, and right heart catheterization, which is used to evaluate hemodynamics and to guide management, they saw that in-house mortality among women tended to be higher than that among men. And the use of revascularization, mechanical circulatory support, right heart cath therapies that could potentially be life-saving or could help to determine management and outcome tended to be used a lot less in women compared to men, and that there were also some differences along the lines of sex when it came to the disparities in women. For instance, if you look at in-house mortality, Hispanic women tended to have a higher in-house mortality among the women, and revascularization tended to be lower in non-white women compared to white women, and mechanical circulatory support was less used in white women and higher in Blacks, and right heart catheterization tended to be lower in Black and white women and higher in other women. So you can see that, you know, just as a whole, women tend to receive differential care in various aspects of cardiovascular disease, but we also see that there's differential use by race. This is a study looking at the incidence of heart failure. So heart failure, again, is my specialty, and I tend to manage patients who have advanced heart failure, who are on the trajectory towards needing mechanical circulatory support and heart transplant. But so we'll talk a little bit about that, but this is looking at the incidence of heart failure by race, ethnicity, sex, and age. And what you can appreciate from this slide is when you look at various age groups, you can see that there is a disparity along the lines of race. Black males and Black women tend to have higher prevalence of heart failure at any age above 55. The prevalence, the incidence tends to be higher among men, Black men, but even Black women in some age groups have higher incidence of heart failure than white men, which is the second highest group. And this is particularly at younger ages. So we know that heart failure disproportionately affects Blacks, tends to be diagnosed at in younger age groups, and that there tends to be a higher prevalence of risk factors for heart failure. When we look at heart failure hospitalizations, which tend to be associated with higher mortality, we see that over the past 20 years, heart failure hospitalizations have declined, but the disparities between Blacks and whites continue, they persist, and Black men tend to have the highest risk of heart failure hospitalization, followed by Black women. So you can see that there are clear discrepancies here. And I've mentioned therapies for heart failure. So there a lot has changed over the past 20, 30 years as far as medical therapy for heart failure. And we're starting to see improvements in survival with the best medical therapies. And we have other therapies such as CRT that can improve quality of life. But in patients who fail these therapies, we have transplant and mechanical circulatory support that not only are they used to cure heart failure, transplant would be considered a cure for heart failure, but patients who undergo these procedures tend to have improved survival, tend to have much better quality of life. So we've moved from the experimental realm with some of these therapies to these being standard of care in patients with end-stage heart failure. But what we're finding when we look at race and sex is that there are disparities in application of these life-saving therapies. And there are a variety of reasons. Insurance may be part of it, the decision-making process. Most of the time, the decision to transplant someone or to implant LVAD is based on committee. And when studies have investigated how these decisions are made, we find that there's bias in the decision-making process itself. We see that female patients with VADs who receive VADs are then less likely to receive heart transplant. They're more likely to be removed from the wait list if they're listed for heart transplant, and they tend to have a higher risk of waitlist mortality. And that's just looking at all women. Blacks and Medicare beneficiaries are less likely to receive LVAD, again, a life-saving therapy, and Medicaid and Medicare patients, and Blacks tend to have a high prevalence of having Medicaid and Medicare, tend to be less likely eligible or deemed eligible for transplant, again, based on committee decision. And Medicaid patients tend to be less likely eligible for destination therapy LVAD. So we see that there are some problems in how these therapies are allocated. Perhaps there's interaction between race and insurance provider, but that being as it may, we know that there are some clear disparities. When we look at the evaluation process, there's a very interesting study where Khadija Breathed, who I think was actually a medical student here, sent out surveys to heart failure providers, to patients or physicians who not only practice in heart failure, but advanced heart failure. So people who are making these types of decisions every day. And they were given a clinical vignette to look at. And everything was the same. She tried to make everything the same except for the race. And so she did this with both men and both women. And the patient would look the same. There would be a photo. They would, in the case of the men, both had beards. I think they're bald. Everything seemed to be the same, and the clinical vignette tended to be the same. But despite that, she found that there were disparities along the lines of race in these evaluations. And what has been found is that there's a tendency to subjectivity in these decisions. So, which means that if your committee is biased, then you end up with disparities due to provider bias. Women tended to be less likely eligible and listed, as I mentioned before. There is differential perception of support for women compared to men. So women have always traditionally been caretakers of their family. They tend to put themselves first. And when it came to determining whether women had social support to undergo transplant and LVAD, they were deemed to have less social support than the men. And this was true, I think, across race lines. African-American women were judged more harshly regarding social support. This tended to do with childcare issues, transportation issues, maybe work-related issues. And this is a typo. Children tended to be liabilities for women. So women have the kids, they take care of the kids, and when it's time for them to receive health care, children tended to be perceived as a burden and a reason to not provide these therapies. There may also be some important biologic differences in women that may account for some of the differences that we see in prevalence of cardiovascular disease and outcomes. Microvascular dysfunction has been cited as being more prevalent among women than men, which may account for the difference in the type of coronary disease that we might see in women. We might see more microvascular disease when they undergo coronary angiogram. The presentation, this might account for the presentation and the tendency to have vasospastic angina. Exposure to HLA antibodies. When we evaluate someone for transplant, one of the determinants in receiving an optimal match is the prevalence of HLA antibodies. And when you have high levels of these antibodies, we refer to this as sensitization. And we know that this tends to be more prevalent in women. Women tend to be more exposed to antibodies due to pregnancy. There tend to be higher prevalence of certain types of antibodies among African Americans. And so these antibodies may put patients at a disadvantage when it comes to transplant. And as I mentioned, higher levels of inflammatory markers have been demonstrated in women. We talked a little bit about social determinants of health. And this was an interesting study, just looking at the specific aspects of social determinants of health and how they related to the differences between Black, white, and Mexican American women. And if you look on the left-hand column, so the way to interpret this is the factors that are above the line are factors that if they were equal between non-Hispanic Blacks and whites, or Hispanics and whites, would increase the cardiovascular score, cardiovascular health score. So the higher the score, the better the health, the lower the score, the worse the health. And so what they found was in Blacks and Hispanics, education accounted for some of the difference in cardiovascular disease risk factors. And also in Hispanics and non-Hispanic Asians, they found that if the place of birth, the country of birth were similar, they would have a lower score. So in fact, not being US born seemed to have a better impact on cardiovascular health score, but education seemed to account for the difference between a poor score and a higher score, if that makes sense. So, and then when they looked at the differences between non-Hispanic Blacks and Mexican American women, these factors tended to account for a little difference between these populations. And so that was just getting at what accounts for some of the disparities among races. I do want to mention a little bit about pregnancy, and I know there's a lot of information and awareness now among around pregnancy-related complications. And race and ethnic disparities exist in pregnancy-related mortality and pregnancy-related complications. And Black, Asian, and Hispanic women tend to have a higher prevalence of pregnancy-related complications, such as eclampsia, preeclampsia, and other risk factors such as obesity tends to be more highly prevalent among Black women. Well, why is this important? If I can get to the next slide. There is a clear link between certain types of pregnancy-related complications and cardiovascular disease. And these two tables show the relationship based on meta-analysis between hypertensive disorders of pregnancy, preeclampsia, for instance, gestational diabetes, preterm delivery, small for gestational age, and pregnancy loss. And all of these increase or are related to different types of cardiovascular disease. Dyslipidemia, for instance, is associated with gestational diabetes and pregnancy loss. Patients who have gestational diabetes tend to be at risk for diabetes later in life. Hypertensive disorders tend to increase the risk of having hypertension later on. And also there's evidence that these women might be more prone to diastolic dysfunction. So, one word of caution in looking at these data, and hopefully this has been mentioned, and I'm sure it's been brought up, race is not a biological variable, even though we are using it as such. It's a social, it's a geopolitical construct, and we have to keep that in mind. And it does help us in some ways to understand disparities and help us to recognize that racial disparities exist and help us to try to investigate the causes of that. But when you look at aggregate and disaggregated data, you can get different results, variable results, depending on the population that you're looking at. And so just going back to this particular study, when you compare US-born non-Hispanic Blacks and non-US born non-Hispanic Blacks and look at the prevalence of preeclampsia, you'll see that they're different. So you just have to be careful when we talk about women of color, and because there's more to that story. And hopefully, as we perform more investigation into healthcare disparities, we can take this into account more. And so this is a nice slide, achieving cardiovascular health equity while recognizing the heterogeneity of Black women. But I think just looking at this, how do we address these disparities? What can we do? What can you do to address these disparities in outcome and access? It's a complex complex situation, right? There are barriers along every aspect of healthcare, but what we can do as clinicians, we can address our own bias. We're participating in a study, again, by Dr. Breathitt, which in which she records our evaluation process for advanced therapy. So I've mentioned that she found that perhaps the decision-making process can account for some of the variable outcome in patients who undergo transplant or in the application of transplant and mechanical circulatory support. So part of this is to get to the decision-making. Where is the bias, and to help us understand our bias and to introduce an intervention in the evaluation process. So we'll see how that shakes out. But I think, we all have some degree of bias, and understanding that and addressing it is going to help our patients. Diversifying the healthcare workforce, right? 3% or less of physicians are Black. And we know that, particularly in heart failure, Black patients are overrepresented. So diversifying the healthcare workforce is going to help with that. Enhancing clinical trial representation. Women, minorities are woefully underrepresented in clinical trials. So when I was asked to give this talk on cardiovascular disease and women of color, I thought, oh yeah, I know that. And then when you really start digging deep, it's difficult to find the information that we need. There's been a lot of emphasis on identifying the disparities, and that's important, but we also must move beyond that to improving the outcomes and narrowing these healthcare disparities. So I won't go through every aspect of this slide, but I think this is the name of the title of the paper, if you can get it, and I can give you the reference. It's very good paper to read. So in conclusion, disparities exist in all aspects of cardiovascular disease and along the continuum from access, from the referral patterns, all the way to the application. And even when patients are at the table being discussed for advanced therapies, they might not get it. And even if they get it, perhaps there are some biological aspects that may impact outcome and their access to transplant. We desperately need more investigation to help us understand these differences and to help narrow the gap. Inclusion in clinical trials, again, that's where we're lagging. But ultimately, we have to move beyond. And I think personalized medicine, AI, these are things that are going to help us in the future. And I'm not saying ignore race, because it's still there, and people, there are disparities along the lines of race. But as far as treatment and application of therapies, perhaps we'll become much more sophisticated in what we do and eliminate that as a barrier. So with that, I'll end. Thank you.
Thank you so much, Dr. Colvin. We're going to set up for the Q&A, and I'm going to start us out with a general question and then go to questions in the chat as they come in. So again, to the students in the audience and anyone else, please place your questions in the Q&A, and I will pass them on to the speakers as we go along. So I think everyone has had a little stretch break, so I'm gonna dive right in. So there's a question we get from students all the time, and even interns as they come into Michigan Medicine is how can they help? What can they do? And so what advice would you give to a student entering residency who is interested in being a change agent for healthcare disparity? How should they start? What should they do? What is feasible when you're M1 coming into a big institution? You have quizzing every week, you have all these work, but you're passionate about healthcare disparities. In your field, what can they start with? And I'm gonna, Dr. Marsha Pleasant is ready to go first, and then I'm just gonna go around the room and let everyone else chime in.
I like that question, and at the same time, it's a very challenging question to answer. I like it because it's really important that you all are here today and that you hear about this data, because there are many people that don't actually know this data. They don't know that Black people may be undertreated for their pain. They don't know that Black people are at a higher risk of breast cancer and cardiovascular disease, right? So knowing these things is the first step. The action part is tricky because there are so many layers to that. When we talk about social determinants of health and we talk about systemic racism, I was just explaining this to someone the other day, that the challenge with systemic racism is that it's everywhere. It is so incredibly embedded in every single thing that we do, how we work, how we breathe, how we act, how we go about our days, that some of it is very easily unnoticeable. If you are a person that is busy, if you are overwhelmed with your clinical duties, it is very easy to miss certain things in our busy lives, because that racism is so deeply embedded in everything. And so if I could give one piece of advice, and I'll give some that are more specific to breast cancer, but my first piece of advice is question everything. When you start as a practicing physician, as a resident, start questioning every single thing that you do. And I recognize that that can be a very exhausting task. But Dr. Morgan and I know very well that the VBAC calculator was a tool that was used all the time in OBGYN. I used it as a resident. People didn't think twice about that tool until people started thinking twice about that tool and saying, oh my gosh, this tool perpetuates racism because it's not actually based, some of it is not based on science, right? And that we are providing people disparate care based on the results of this tool. So it took people actually asking those questions about it, and then it forced that conversation nationwide, globally, for us to really revisit this thing that we thought was really true, and it wasn't, right? So question every single thing, and don't get so wrapped up in your day-to-day, in your work and your clinical duties, which are important, but don't forget that your patients, your community need you to look at everything with a very, very careful, discerning eye. In terms of, just switching gears a little bit, in terms of breast cancer, depending on what you pursue as a specialty, I guess I'd speak a little bit more to people that may be more in the primary care setting. I would say not only remembering some of the data that I presented to you today, but more tangible things. There's a lot of very, very conflicting data regarding when people should start mammograms. Should they start it at 40? Should they start at 45 or 50? Or later than that? Should they have them every year, every 2 years? We go by the American College of Obstetrics and Gynecology, which is start at 40 and offer it every year to your patients. There is, as you can see, breast cancer is so prevalent in this country. I don't think that people can really afford to wait until 50, especially people that are a higher risk, to start having mammograms, and that they should be every 2 years. I think they should be starting at 40 every single year. And I would offer that to all of your patients. The other thing too is taking a really good family cancer history. And this does not need to be something that takes a lot of time, but just saying, hey, do you have any family members with cancer? Breast, ovarian, prostate, pancreatic, right? The genetic testing guidelines change all the time, and they are very detailed. But here are some things that should be red flags for you. If a person says, oh, my father had male breast cancer, that's a red flag. That person needs to go to genetic testing. Oh, my grandmother died of ovarian cancer, red flag. Any ovarian cancers, any male breast cancers, any pancreatic cancers, those are automatic red flags. Close family members that have had triple negative breast cancer, that's a very aggressive cancer, automatic genetic counseling and testing. Or multiple family members with breast cancer, or young, early onset breast cancer earlier than the age of 50. And the worst thing is that you refer someone to a genetic counselor and that person doesn't meet criteria, right? And that's okay. But it could be more detrimental if that person actually could be high risk and they were not referred. So it never hurts you to refer if you have a question mark in your mind.
Thank you, Dr. Pleasant. Dr. Colvin, would you like to address that question again regarding, what can early medical students or any residents or do?
Mhm. I think as Dr. Pleasant mentioned, it's a tough question because there's so much going on. I think what I noticed over the years is that there's a greater interest now in formally addressing disparities. We have OHI and there are various resources. And so I would say first, maybe connecting yourself with one of these groups would be a good way to get started. But you're busy, and just arming yourself with knowledge and as Dr. Pleasant mentioned, asking questions. And you brought up, I missed your talk, but in the kidney world, which impacts the heart transplant world, there is this use of a race based EGFR calculation. And forever disadvantaged Blacks on the kidney transplant wait list because it overestimated renal function. And so, people were not getting treatments that they needed. And this recently changed and resulted in, having to readjust, people's status on the wait list for kidney transplant. But again, these are things that have been accepted that no one has questioned. So when you're seeing things that don't make sense to you, or you just want to know why, don't be afraid to ask why these things exist. But I think as a student, at some point, everyone gets involved in research and clinical trials. Well, maybe research, but perhaps that's a good way to maybe get started in looking at healthcare disparities, and perhaps in some cases addressing them and understanding them. You can work with an investigator perhaps to look at specific aspects of disparities, or perhaps work with someone who's doing clinical trials and understanding recruitment patterns and things like that. So I think perhaps research is a way to get involved and have an impact on what happens down the road in developing various treatments and understanding and developing interventions to address not only therapy, but systemic bias, as we're doing with one of our studies. So that might be a way, but finding that person, maybe your mentor, someone that you trust, to become a resource for you who can also help guide you in this path, because I think it can be daunting as a first year.
Dr. Hillard, I'm going to have you comment on that question, and then I have a specific question for you from the chat.
Yeah, what can you do? I think it's a good start that you're here with us tonight, right? This is really where it starts. I think it is incumbent upon you to be knowledgeable about these things. It was shocking to me that in 2016 we had people going into medicine who were ill-informed about this, and so you're taking a great first step. I think it's just critical to stay abreast of this, keep it on your radar screen. There will be a lot of things competing for your interest over the next several years. If you're going into medicine, or if you're already practicing, that there are a lot of things to juggle, but this should be front and foremost in your thinking.
And yes,
and I do see the question in the chat that was directed to me. What is an effective way to start a conversation with an inpatient about managing their pain? At times I see my patients suffer and wait until rounds rather than informing the nursing staff, looking for effective communication tools. Yeah, that's a really great question. And, I think it's a little different for every patient. In the inpatient setting, I think you kind of learn to read the room a little bit when you go in there. Some people may respond better to humor. Some people may need an icebreaker. I think once a patient understands they can partner with you, they can talk to you, they will communicate more effectively with you. and just ask them, you just ask them, how'd you sleep last night? What kept you awake? Was it, are you comfortable? There are a lot of comfort measures you can bring. A certain amount of pain is expected with certain types of admissions, but there is a lot we can do to make patients more comfortable. So learn to read the room and just direct communication with them, and make yourself available to them.
Thank you, Dr. Hood. Dr. Morgan, I'm going to have you comment on the first question about students who are interested in healthcare disparities. How do they start? And then there's a general question that I want you to address too after that.
Sure. I think part of it is taking care of yourself, because medical training is hard. And anything you can do to protect that fire inside of you, I think, is such an important thing. At our medical school, we do have that wonderful path of excellence on healthcare disparities. That is a nice way of connecting, because sometimes it's hard to connect with the people who are doing the work. And then, there's an ebb and flow of medical school. Then you kind of go into the clerkships, and that takes, and that's the time when you just kind of focus on the patient in front of you and doing the best for that person right there. And then there's more opportunities later in the curriculum to really delve into a topic, but it's just about kind of making all those connections with people so that you can find somebody to maybe do a great research project with during your 3rd and 4th year.
Yeah, thank you. The general question, I'm gonna make sure that I'm interpreting this right for that student, but I know that students of color often get placed on remediation at a higher rate than white students, and some of it is attributed to assessment and bias in assessment. And so there's a question that how do I demonstrate that I've mastered understanding of medicine as a minority? Because sometimes students feel like they have, but when they get their grade, it doesn't demonstrate mastery. And so they're concerned about, is there bias? Did I not understand the hidden curriculum? Just wondered if you'd comment for that student.
Yeah, no, I think that's a great question, and you bring up all of the other factors that are associated with grading, especially when grades involve being compared to other students. And that's the model that we need to everybody needs to move away from the model where medical students are being compared to each other, because that's when racism and biases always emerge even more strongly. I would encourage the student to ask for feedback as much as possible, because that's how we grow. I think that mastery is always a hard goal. We're all trying to become the most competent versions of ourselves, and getting feedback on where are the areas where I'm doing an amazing job and where are the areas that I need to focus on, I think helps me to break it up into more, where are the specific skills and areas that I need to work on, is the advice I would give.
Thank you. Are there any other comments on that last question about demonstrating mastery of medicine, and any of the other speakers would like to comment on? We have about a minute. Yeah. Okay. So I want to really thank our speakers tonight. I want to thank you, Dr. Pleasant, Dr. Hiller, Dr. Colvin, and Dr. Morgan, for sharing your expertise with us and taking this time out of your very busy evening, dinner time, family time to impart this knowledge. I also want to thank the OHEI faculty and staff for all their work around this, and in particular the people behind the scenes like Sue Schreck and Peggy Wright and Brandon James, who work behind the scenes to get all of this together. I hope we demonstrate tonight that at Michigan Medicine that we're committed to reducing healthcare disparities. And we hope that you will join us in this path to health equity through health justice. I look forward to any questions you may have. Send them to us by email. We're happy to answer them. If I can't, I'll find the right people. Thank you very much and have a good night.